The triple-action ankle joint was developed to enhance the clinical impact of orthotic care for a broad range of pediatric applications. Through this program, you will discover how this unique orthotic component can raise the level of your clinical practice while creating opportunities for collaboration with other allied healthcare professionals. This accredited online learning program covers the theory of operation as well as the technical and clinical applications of the pediatric triple-action ankle joint. The program will begin with a general discussion of pediatric AFO functional types. AFOs directly influence ankle motion by applying forces across the ankle joint in three-point bending. These orthoses indirectly influence knee motion by manipulation of the ground reaction force with respect to the knee axis. This orthotic influence at the ankle and knee results from the AFO's ankle alignment and resistance to ankle motion. This influence may be fixed or adjustable. There are many types of pediatric AFOs, but the sagittal plane influence of all types may be represented by some combination of the leaf spring, plantar flexion stop, and dorsiflexion stop orthosis. Leaf spring AFOs permit active resisted ankle motion when the ankle moves away from the fixed ankle alignment of the orthosis. These orthoses are commonly used to treat mild swing phase gait deficits as well as foot and ankle postural abnormalities. Plantar flexion stop AFOs provide high resistance to plantar flexion at a fixed or adjustable flexion angle while permitting free dorsiflexion. These AFOs find application in the treatment of spastic equinus with or without knee hyperextension. Plantar flexion stop orthoses are not used to treat knee flexion instabilities or spasticity. Dorsiflexion stop AFOs provide high resistance to dorsiflexion at a fixed flexion angle while permitting free plantar flexion. Dorsiflexion stop orthoses are used to treat knee flexion instabilities resulting from knee extensor insufficiency or crouch gait resulting from knee flexion spasticity or contracture. Dorsiflexion stop orthoses are not used to treat plantar flexion spasticity or when there is spastic co-contraction at the knee, such as in jump gait. The solid AFO is the combination of plantar flexion and dorsiflexion stop types. These orthoses have fixed ankle alignment. Solid AFOs are typically used for static positioning to maintain range of motion, or to provide support for the ankle and knee when combined with tuned shoe rocker modifications. Triple-action AFOs provide features found in the other functional types in addition to independently adjustable resistance, range of motion, and alignment adjustments. These orthoses are well suited to the management of complex, combined, or changing ankle and knee deficits. Triple-action AFOs can be used to actively treat plantar flexion spasticity, knee hyperextension, knee flexion instabilities, or crouch gait. They are also suitable for post-surgical support and can be used for contracture management. This discussion is focused on the theory of operation and is intended to help explain how this unique orthotic component can be used to impact the design and function of pediatric AFOs. To explain how the triple action works, its operation will be compared to the more familiar double-action ankle joint. The double action is a versatile orthotic component that can be used to assist or block ankle motion depending on whether springs or pins are installed in its anterior and posterior channels. Double-action springs provide moderate resistance to ankle motion, making them best suited to the management of mild swing phase gait deficits. These springs permit a high range of active motion, and so are best suited for patients with low activity levels. This animation illustrates how the stirrup moves inside the double-action ankle joint. Note that as the stirrup moves, The springs maintain contact with the stirrup head throughout its entire range of motion. The design of the double action links the springs together through the stirrup head and makes the dorsiflexion assist, plantar flexion assist, and alignment functions interdependent. This interdependence reduces the component's effective resistance to ankle motion and may significantly shorten the service life of the springs. Although the triple action ankle joint resembles the double action in its outward appearance, it functions very differently on the inside. The triple action is a highly versatile orthotic component that can be used to resist or block ankle motion. Triple action springs contain internal motion-limiting pins in the anterior and posterior channels. Since triple action springs provide high resistance to ankle motion, they are well suited to the management of severe swing and stance phase gait deficits. Triple action springs are highly durable, making them an ideal choice for the most active patients. This animation illustrates how the stirrup moves inside the triple action ankle joint. Note that as the stirrup moves, the springs make and break contact with the stirrup head. This make and break contact isolates the actions of the springs, allowing the resistance, range of motion, and alignment functions of the triple action to be independent. This design increases the active resistance of the component and also helps increase spring cycle life by more than 20 times when compared to traditional metal ankle components. Triple action springs provide higher resistance than double action springs. All triple action ankle joints come standard with 2 spring options: Spring 1, standard resist, and Spring 2, high resist. With the addition of the optional booster spring staged resist adapter, or SRA, a total of 5 unique spring configurations are possible. The booster spring SRA can be installed in the plantar flexion resist, dorsiflexion resist, or both spring resist channels. Booster spring configuration number 4 also gives the triple action the unique ability to vary its resistance as the stirrup moves through its range of motion. This feature is called staged resist. The ankle angle at which this change of resistance occurs is adjustable when tuning the triple action in the clinical setting. This slide illustrates the staged resist feature of the triple action ankle joint. As the stirrup begins moving away from its null position towards dorsiflexion, the black spring under the booster spring SRA begins resisting motion. During the second rocker of gait, this resistance may substitute for the eccentric contraction of the gastrosoleus. At a clinically determined dorsiflexion angle, the red, high-resist spring inside the SRA also begins resisting motion. This high active resistance may help to slow the progression of the tibia in late stance. The combined action of the 2 springs in the booster spring SRA can be tuned to stabilize the knee against flexion, while limiting hyperextension in late stance. This slide illustrates how to adjust range of motion. The range of motion in plantar flexion and dorsiflexion may be independently adjusted. Turning the adjustment screws clockwise decreases range of motion by 5 degrees per turn. With the adjustment screws tightened fully clockwise, the component's range of motion is locked at 0 degrees. This is the reference setting for the component's range of motion adjustment. Turning the adjustment screws counterclockwise increases range of motion by 5 degrees per turn. The maximum active range of motion is 15 degrees or 10 degrees, depending upon which spring configuration is installed. The following animation will illustrate the effects of the range of motion adjustment for 2 spring options: standard resist spring number 1 and booster spring number 3. Booster spring number 3 exerts twice the force of spring number 1. Please note that the units of force used in this illustration are arbitrary. In this animation, the stirrup articulates between its null position and its initial range of motion setting of 15 degrees. The maximum force, exerted by standard resist spring number 1, is shown. When the adjustment screw is rotated one full turn clockwise, the range of motion decreases by 5 degrees, but the maximum force on the stirrup doesn't change. When booster spring number 3 is installed, the maximum force exerted is twice the amount of spring number 1. Rotating the adjustment screw one full turn clockwise decreases the range of motion by 5 degrees, but again does not affect the maximum force. This animation illustrates that the maximum resistance of the triple action ankle joint is determined only by the spring configuration. The range of motion adjustment screws change the articulation range of the stirrup, but do not affect stirrup alignment. The alignment setting rotates the component body about the pivot bushing, maintaining the joint center as the component articulates. The alignment feature is unlocked by loosening the central locking screw and adjusted by rotating the outer hex. The independent action of resistance, range of motion, and alignment have been shown to systematically influence gait in biomechanical studies. The effect of these component settings may also depend upon the nature of biomechanical deficits. Separating the influence of component settings also facilitated the development of the triple action tuning procedure. This procedure helps to simplify adjustments in the clinical setting. The triple action tuning procedure resembles prosthetic alignment and will be described in greater detail later in this presentation. AFOs can help kids walk better and more independently. They can also help to maintain range of motion or decrease pain following surgery. The triple action ankle joint was developed to maximize the clinical benefits of pediatric AFOs. The features of the triple action ankle joint include independent alignment, range of motion adjustment, and multiple spring configuration options. Triple action springs have high active resistance and are durable enough to keep up with the most active patients. The triple action is effective at managing high-activity patients with complex, combined, or changing neuromuscular deficits. Indications include lower extremity gait deficits as the result of cerebral palsy, spina bifida, and other pathologic neuromuscular conditions. The triple action was developed to treat pediatric patients through all stages of orthotic management. To improve the function of active ambulators without locking up the ankle, for rigid immobilization and pain relief after tendon release surgery, followed by incremental mobilization of the ankle during rehabilitation, and as an adjunct to Botox injection. The triple action's alignment feature has a 20-degree adjustment range and may be used to maintain or further increase range of motion after serial cast removal. These three applications of the triple action ankle joint span the full range of pediatric lower extremity orthotic care and demonstrate the versatility of this unique orthotic component. The triple action enhances the clinical impact of AFOs and provides an orthotic solution that fits within the current structure of healthcare reimbursement. Although correct coding is the sole responsibility of the facility assuming the insurance claim, suggested L codes for triple action billing are L2220 and L2999 for the addition of the alignment feature. If the L2999 code is also used, we suggest the following wording be used as a descriptor: addition to lower extremity, independently adjustable, sagittal ankle alignment, each joint. Options and accessories are available for the triple action ankle joint to equip the clinician with the tools they need to help them tailor their orthotic design to the unique needs of their patient. 2 spring options, adjustment wrenches, metric attachment screws, lubricant, and thread locking adhesive are included with the triple action ankle joint. There are 2 stirrup options available: a universal lateral stirrup and a medial stirrup, which is ordered specifically for the right or left leg. The booster spring SRA is also available as an option and includes standard and high-resist springs. The fabrication kit includes an alignment axis, 2 component dummies, bushings, shoulder screws, and wrench. In this section, fundamental aspects of triple action AFO design will be discussed. The success of the clinical outcome starts with effective orthotic design. Triple action AFOs must be rigid to systematically influence sagittal plane kinematics. AFOs that are too flexible will decrease the systematic influence of the component on gait. Becker Orthopedic is engaged in testing aimed at improving the design and fabrication of triple action AFOs. Rigid thermoplastic materials such as polypropylene in a sheet thickness of 4 mm or 5/32 of an inch are recommended. Stiffeners at the distal calf may also be used to increase stiffness depending on the shape of the limb, patient weight, calf diameter, and neuromuscular tone. Ventral or pretibial shells are recommended with full-length foot plates for applications where knee flexion instability or spasticity exists. The pediatric triple action is not intended for use in composite AFO designs or designs without a companion joint. The decision whether to use 1 or 2 triple action components for a particular AFO design should be based on patient weight, calf circumference, and neuromuscular tone. This chart is intended to provide general guidelines for component selection for pediatric triple action AFOs. The first consideration is patient weight. The patient's level of spasticity is then used to determine whether 1 or 2 triple action components is appropriate, with or without booster spring SRAs. 1 triple action paired with a medium tamarack companion joint will be suitable for many applications. It is recommended, however, that all post-surgical AFO designs use 2 triple action components to ensure maximum stability, even for smaller, low-tone patients. The maximum recommended weight limit for the pediatric triple action is 50 kilograms, or 110 pounds. In some cases, the component may be appropriate for a heavier patient depending on their spasticity and activity levels. Please contact a Becker Orthopedic customer service representative for assistance with these clinical applications. As patient weight, calf circumference, and spasticity increase, additional spring force and shell stiffness are required. This illustration summarizes the general recommended starting point for triple action AFO designs. 4 mm or 5/32 of an inch polypropylene is recommended for pediatric triple action AFOs. This thickness may be reduced for some designs by using stiffeners to enhance rigidity. If a single triple action is used, stiffeners may be required for moderate size or spastic patients. Stiffeners placed at the distal aspect of the calf section may improve the rigidity of the orthotic shell. Using two triple-action components will achieve maximum stiffness and will also provide the highest active resistance to ankle motion. There are just a few special considerations when fabricating AFOs using the triple-action ankle joint. The following section will provide the orthotist and technician with some useful tips. Prior to fabrication, the ankle angle of the mold should be corrected to the clinical management angle. This will determine the AFO footplate position when the triple-action alignment setting is set to 0 degrees. For active ambulators, the starting point for the clinical management angle should be set to 5 degrees of dorsiflexion. The patient's ankle should possess range of motion above and below this position. If the patient's dorsiflexion range of motion is limited, correct the mold to the patient's maximum dorsiflexion angle at R2 by Tardot, evaluated non-weight bearing with the knee fully extended. Please note that the orthosis or shoe may need to be posted to accommodate this ankle position with the shank inclined. If the AFO is used to manage a plantar flexion contracture, correct the mold to the dorsiflexion alignment anticipated at the end of contracture management. Set the alignment axis 13 to 25 millimeters or 1/2 to 1 inch proximal to the anatomical ankle axis. This will position the stirrup above the collar of the shoe. Shifting the mechanical axis proximal to the anatomical axis will have minimal effect on relative movement between the orthosis and the patient's leg, but will dramatically improve the fit of the shoe. Verify that the distal aspect of the lateral stirrup is above the lateral tubercle of the heel and base of the 5th metatarsal. If you are using a medial triple-action component in your orthotic design, be sure to verify that the distal aspect of the medial stirrup is plantar to the navicular. Drill a 9.5 millimeter or 3/8 of an inch hole through the mold and insert the alignment axis. Fill and strip the mold and remove the alignment axis from the positive model. The upper bar and stirrup must be removed from the component prior to assembling the fabrication tool for fabrication. The fabrication dummy included with the fabrication kit holds the upper bar and stirrup in alignment during fabrication. To disassemble the triple-action component for fabrication, first, slightly loosen the adjustment screws to reduce the preload of the springs on the stirrup head. Remove the E-clip using the included combination wrench. Remove the pivot bushing. Remove the stirrup, nylotron washer, and upper bar from the component body. To assemble the fabrication tool, correctly orient the stirrup and upper bar with the component dummy. Insert the shoulder screw through the pivot hole in the stirrup, dummy, and upper bar, and attach the alignment bushing. Ensure that the stirrup head is seated firmly against the fabrication dummy alignment pin. Gently tighten the alignment bushing using the combination wrench and 4 mm hex wrench. The alignment bushing fits into the hole in the mold formed by the alignment axis. It is important not to bend or mar the upper bar and stirrup where they contact the component. Doing so will damage the component. Prepare the mold for thermoforming and lightly coat the component using talcum powder or cornstarch. Heat the polypropylene sheet to a thermoforming temperature of 185 degrees Celsius or 365 degrees Fahrenheit to stress relieve the sheet. If using a transfer pattern, be sure to spray the film with a release agent. Transfer the pattern and thermoform the orthosis. Draw the trim line 45 mm or 1 3/4 inches proximal to the joint center for the tibial section. Draw the trim line 19 mm or 3/4 of an inch distal to the joint center on the foot plate section. Reassemble the triple action. First apply Teflon grease to the stirrup and pivot bushing. Also apply grease to the keyhole-shaped slot in the upper bar. Attach the upper bar to the component body. Note the placement of the nylotron washer. Insert the stirrup and install the pivot bushing. Finalize assembly by reinstalling the E-clip. Lastly, verify that the component articulates freely after assembly. If a free motion companion joint is used, install the joint on the medial side of the ankle. A good choice for a companion joint for the pediatric triple action is the medium-sized tamarack flexure joint. The tamarack, when installed using tamarack caps, has been validated through mechanical testing as a suitable companion joint for pediatric triple action AFOs. Tamarack caps improve AFO stiffness and minimize joint motion while improving the control of total contact footplates. Be sure to apply thread-locking adhesive to all bar attachment screws to finalize fabrication. Tuning a triple action AFO is faster and easier than you may think. This section takes you step by step through the clinical application of a triple action AFO, including the tuning procedure to help you achieve the optimal outcome for your patient. The triple action tuning procedure focuses first on segmental tuning by defining specific events for observational gait analysis. The procedure is a useful starting point for a broad range of clinical applications. This procedure consists of bench adjustment, static alignment, swing phase alignment, and stance phase adjustment. Prior to beginning the tuning procedure, the appropriate spring configuration must be installed. For this example, let's assume that the patient presents with hemiparetic gait type 2 as defined by Rada et al. This posture is described as true equinus with knee hyperextension. Let's also assume that the patient weighs 30 kilograms or 66 pounds and has high spasticity. Becker Orthopedic provides general guidelines for the selection of the orthotic design for gait patterns in spastic cerebral palsy. These guidelines are intended to serve only as a starting point for the design of triple-action AFOs. Based on these guidelines, the design of the triple-action AFO for this patient would be a dorsal, also known as a posterior calf section with a sulcus-length footplate. A single triple-action ankle joint would be used with a booster spring SRA. This slide summarizes the features of this particular AFO design. The orthosis would be fabricated using 4 mm or 5/32 of an inch thick polypropylene sheet. The triple-action component would be mounted on the lateral side of the AFO and paired with a medium-sized tamarack flexure joint with caps on the medial side. The joint axis would be mechanically aligned but shifted 13 mm or 1/2 inch proximal to the apex of the lateral malleolus. The triple action would be configured with booster spring number 4 in the plantar flexion channel and spring number 2 in the anterior channel. This video illustrates installation of the high-resistance spring configuration number 2. First, remove the standard resistance spring and motion limiter pin from the component body. Use the grease included with the component to lubricate the red motion limiter pin and insert the pin into the red high-resist spring. Wipe the excess grease from the outside of the spring. Insert the ball bearing, spring with motion limiter pin, and adjustment screw back in the spring channel to complete installation. This video illustrates the installation of booster spring configuration number 4. The booster spring comes with the red high-resist spring and motion limiter pin pre-installed. Use the included grease to lubricate the booster spring pin and then insert the pin through the standard resist spring. Wipe the excess grease from the outside of the spring. Apply a small drop of thread locker to the thread on the SRA. Insert the ball bearing and booster spring in the spring channel and gently tighten using the combination wrench. The first step of the triple action tuning procedure is bench adjustment of the AFO. To bench adjust the AFO, first reduce the range of motion in dorsiflexion and plantar flexion to 0 degrees by turning the adjustment screws fully clockwise. Adjust the alignment setting to 0 degrees. This video illustrates the bench adjustment procedure. Bench adjustment locks the AFO and positions the ankle angle at the clinical management angle. The second step of the triple action tuning procedure is static alignment. Don the AFO and shoes. With the patient standing, use the triple action alignment setting to tune the shank to vertical angle. A convenient way to measure the shank to vertical angle is to place an angle finder or smartphone against the tibial crest. The typical starting point for shank to vertical angle is 11 degrees. This video illustrates static alignment. During this procedure, optimize the patient's sense of balance and stability using subjective feedback and objective observation. If there is insufficient dorsiflexion range of motion to achieve stability, it may be necessary to lift the heel of the AFO in the shoe to incline the shank. The third step of the triple action tuning procedure is swing phase alignment. With the patient walking and the range of motion of the triple action component still locked at 0 degrees, observe toe clearance in mid-swing and the angle between the sole of the shoe and the floor. Use the alignment setting to optimize these two gait events. Please note that if there is insufficient range of motion or high tone in the gastrocnemius, increasing dorsiflexion alignment may reduce knee extension at terminal swing and decrease the foot-to-floor angle at initial contact. Observe step-length symmetry by gauging the position of the heel with respect to the contralateral toe during this adjustment. The last step of the triple action tuning procedure is stance phase adjustment. This step involves mobilization of the ankle first in early and then in late stance. The triple action plantar flexion resist function has been shown to systematically influence the swing and early stance phases of gait, while the triple action dorsiflexion resist function has been shown to influence ankle and knee stability after mid-stance. The influence of these functions may be affected by the nature of the patient's biomechanical deficits. Early stance phase adjustment is performed with the patient walking. Begin this adjustment by mobilizing the first rocker. Increase the plantar flexion resist range of motion 5 to 10 degrees. Dorsiflexion resist range of motion will remain locked during this early stance phase adjustment. This video illustrates adjustment of the plantar flexion range of motion to 5 degrees by turning the adjustment screw one turn counterclockwise. Observe toe clearance in mid-swing, as well as foot-to-floor angle at initial contact. If either of these measures decreases with the increase of plantar flexion range of motion, decrease the plantar flexion range of motion by turning the adjustment screw clockwise. Observe knee extension after loading response and before mid-stance. If the knee hyperextends with the increase in plantar flexion range of motion, decrease the plantar flexion range of motion by turning the adjustment screw clockwise. If the plantar flexion range of motion must be set to less than 5 degrees to actively manage the position of the ankle or the stability of the knee, it may be necessary to increase the resistance of the plantar flexion spring by changing the spring configuration. However, the passive range of motion of the ankle in dorsiflexion as relates to ankle alignment should also be considered. Observe knee flexion in first rocker. If the knee flexion is excessive, increase the plantar flexion range of motion by turning the adjustment screw counterclockwise. Remember to count the number of turns of the adjustment screw to keep track of the range of motion setting. The last step of the tuning procedure is the adjustment of the dorsiflexion range of motion to tune knee stability in late stance phase. Late stance phase adjustment is performed with the patient walking. Begin by mobilizing the ankle in second rocker by increasing the dorsiflexion range of motion 5 to 10 degrees. This video illustrates adjustment of dorsiflexion range of motion to 7.5 degrees by turning the adjustment screw 1.5 times counterclockwise. Observe knee flexion after mid-stance. If knee flexion is excessive, decrease dorsiflexion range of motion by turning the adjustment screw clockwise. If the range of motion setting must be set to less than 5 degrees to actively manage the ankle or the stability of the knee, it may be desirable to increase the resistance of the dorsiflexion resist by changing the spring configuration. Observe knee extension after mid-stance. If knee extension is excessive, increase dorsiflexion range of motion by turning the adjustment screw counterclockwise. Remember to count the number of turns of the adjustment screw to keep track of the range of motion setting. This completes the preliminary triple action tuning procedure. Additional fine-tuning may be necessary to achieve optimal results. Guiding the patient toward comfort, stability, and a sense of improved function in the short and long term is a critical aspect of orthotic optimization. Solicit the patient's feedback regarding their sense of stability and comfort. Observe whole body rather than segmental kinematics. Other objective clinical signs that may be useful for component optimization include gross trunk motion, position of the upper extremities, step width variability as an indication of lateral balance, and step length symmetry and variability as an indication of stability. Prior to delivery of the AFO, ensure that the medial and lateral component settings on bilateral triple action AFOs are the same. Torque the alignment lock to 15 Newton meters and chart the spring configurations installed, range of motion, and alignment settings. The Pediatric triple action ankle joint is a durable orthotic component with a high range of adjustability for active management of the ankle and knee. The component separates resist, range of motion, and alignment functions to simplify tuning and make the effective component's systematic influence on gait more visible. Triple action AFOs find application in the full range of pediatric orthotic care, including support for active ambulators, static progressive contracture management, and post-surgical management. Triple action orthoses can impact your clinical practice by providing a treatment program to help standardize and optimize the delivery of pediatric orthotic care, document patient progress, and create opportunities for collaboration with other allied healthcare professionals. For additional information, visit our website at www.beckerorthopedic.com. If you have questions about a specific triple action application, please contact our customer service department at 1-800-521-2192.